Now it is my pleasure to introduce Dr. John Hansen-Flaschen. He is from the University of Pennsylvania and is the Paul F. Heron Jr. Family Emeritus Professor of Medicine at UPenn. He also is the founder of the Jay and Randy Fishman Program for Home-Assisted Ventilation within the Heron Lung Center at Penn, and has quite a long career of great accomplishments working with ALS patients and many others. And I'm going to turn the time over to him to introduce himself much better, but we are so glad that he is here and spending time with us today. So Dr. Hansen-Flaschen, take it away.
Thank you. How many of you have experienced a time when you lost your breath and you couldn't catch it, and it was so bad you thought, oh my God, I'm going to die, I might die? Here's someone that's had that experience. Two people in the room. Lost your breath so bad for whatever reason, you thought, maybe I'm going to die. Total alertness catches your complete attention. Well, most people don't ever have that experience, or not maybe till late in life. If you can't breathe, breathing is everything. It's your whole world. There's nothing else if you can't breathe. I'm going to talk about respiratory care for ALS, provide a vision overview of what this can and should be in the realm of ALS. And I'm going to outline the elements of optimal care as we understand it today, with hope that we get continuously better at this over time. I have a big career in pulmonary and critical care medicine, did a lot of things. Great. That did not include ALS. I saw my first ever outpatient with ALS in 2015. Jay Fishman, he was jetting around the country, meeting with people to learn how best he might approach his new diagnosis of ALS. And Board of Trustees at Penn, they sent him to me, and I told Jay that I had no experience treating this, but I had some general advice on how to live with a chronic progressive disease. That advice was to lean in, learn what's coming, prepare in advance for each loss of function, so as to transition to progressively higher levels of care, while for as much as possible escaping crises and without falling behind. And he really latched onto that. We became good friends, and while he was still alive, he advocated for a leaning in strategy for ALS across the country, speaking, television, writing, in as many forums as he could. And he and his wife Randy gave us a good deal of money on the condition that I would launch a program for neuromuscular diseases, respiratory care of neuromuscular diseases at Penn, that featured this strategy of leaning in, running ahead of declining function and disease rather than catching up from behind. And well, I was trying to retire, but it was a pretty intriguing opportunity. So in 2017, I founded the Fishman Program for Home-Assisted Ventilation at Penn. We're up and running with a staff of 9, 4 physicians, respiratory therapist, nurse practitioner, an RN, a social worker, and other people we engage with, working closely with our neurologists, and they have a separate program for neurology. And we take care of whatever causes respiratory failure and might benefit from mechanically assisted ventilation. I've learned so much in these last several years, reinventing my knowledge and expertise, and really become very much engaged in this much neglected corner of pulmonary medicine. The program is built on an understanding that they're not one, but actually two vital organs of respiration. The lungs for gas exchange, oxygen in, carbon dioxide out, and the respiratory pump, a complicated structure that moves air in and out of the lungs. Now, you die without your lungs, but you die just as sure and just as bad, as hard, without the function of the respiratory pump. The respiratory pump is to respiration what the heart is to circulation. It just isn't as convenient a thing to look at and consider. So we take care of conditions that cause progressive failure of that other organ, that other vital organ, the respiratory pump. As respiratory muscle failure starts to become clinically apparent, people experience breathlessness as they would for lung disease, and very early on and very prominently have impaired sleep that impairs their function during the day and is very uncomfortable, have a weak cough that makes their lungs vulnerable, and then as carbon dioxide builds up in the blood, brain fog, confusion, lethargy. And for progressive diseases, most dramatically for ALS, death by respiratory failure. Respiratory failure remains the single most common and usual expected cause of death in ALS. And this is not just fall asleep and don't wake up. This is through progressive loss of breathing, the anxiety, the terror that goes along with that. Untreated, people with ALS die of suffocation. We have tools to deal with that. And in fact, still today, the single most impactful treatment for prolonging survival in ALS is non-invasive ventilation, mechanically assisted ventilation. This was proven in a small but convincing double-blind controlled trial in 2006. On the right-hand side, you see an improved survival curve for those with normal or minimally impaired bulbar dysfunction. At that time, not so much impact on people with bulbar disease. This was very primitive technology, and before we really learned how to use the machines, but even at that point, the survival advantage for assisted ventilation trumped anything else available, and that's still true today. Good news is we're much better than that today. We don't really have a good fix on the average prolongation of life or quantitatively improvement in survival that's achievable with home ventilation. That randomized controlled study has not been repeated and never will, but indirect evidence points to progressive or altogether preventing an unwanted death by respiratory failure in ALS. The technology is far advanced now. This is it. It's a tabletop machine, size of a child's shoebox, attached by a hose to a mask. Can be done ambulatory or portably. This is Jay Fishman. He was chair and CEO of the Travelers Group, a Dow Jones Industrial Company, and here he is at a professional golf tournament in Hartford, Connecticut, 2016, wearing his non-invasive ventilator and talking to the golf pros that were in the tournament. This is cut from a short video, and it's always impressed me that in that short video, he's sitting and taking breaths, and he was the strongest, most resolute person in this group of athletic professionals. What he was able to do with his disease, with the benefit of non-invasive ventilation, was an absolute inspiration to me. Here's a more recent current patient of mine is carrying his ventilator and walking down the hall with a face mask. He has respiratory onset ALS, so muscles preserved at the time. He's pretty much lost the function of his respiratory pump, 18, 20 hours a day of assisted ventilation. Here he is on a plane using his machine. On a roller coaster at Disney World. See him in the back there with his hat? On a waterboard with a $24,000 ventilator balanced between his legs. The guy is bold and out of his mind, but wanting very much to show what's possible with the benefit of modern assisted ventilation, well-tuned. Bad news, only a small fraction of people in the United States have access to optimal respiratory care for ALS. It's an embarrassingly small fraction of people who can obtain state-of-the-art respiratory care, state-of-the-art care for the major cause of death in this disease and an absolutely major cause of suffering in the second half of the disease. And that shows in our performance. This is an analysis performed in 2019 of the U.S. National PROACT Clinical Trial Participant Database, 1,700 patients enrolled in clinical trials. Non-invasive ventilation was used at the time of only 52% of office visits when the forced vital capacity was less than 50% predicted. That's already severe respiratory insufficiency. Only half of them reported using non-invasive ventilation at that phase of the disease, which is conservatively considered a time to get going with this treatment. And of the people who did initiate non-invasive ventilation, 15% of it subsequently abandoned the treatment. So that's hardly optimal care when people are not doing it in the first place or abandoning it secondarily. We're not doing this very well in the United States. And I want to suggest that there's a lot of reasons for this, but one of them is an outdated model for care of ALS. This is right from the ALS Association website. It's very familiar to all of you that this disease be managed with a multidisciplinary team, in almost all instances headed by a neurologist who has assembled a group of therapists, mostly non-physician collaborators that work closely together to cover the various aspects of the disease as it progresses. In the mix in this ALS Association model, headed by a neurologist, is a respiratory therapist to cover the cause of death of the disease, respiratory failure. Now, physical therapists, occupational therapists, speech pathologists have years of training beyond high school, and many of them are at an equivalent of a practical doctor's degree in their training and expertise, actively engaged in continuing education. Respiratory therapists are really technologists. 2 years of technical training beyond high school. It's confusing, therapists, but respiratory therapists are not trained to the level of a high degree of independence and function like a physical therapist, and people confuse that. These are technologists. This is the EKG technician or the dialysis technician. Some of them are very fine, dedicated clinicians who've learned a lot and have a major impact. But the standard and the default model for ALS, all too often in too many locations in the U.S., respiratory care is delegated to a technician. And this is what it looks like. Not everybody, and not maybe where you are, but so much of the country. A neurologist submits an order, or maybe doesn't, but submits an order for a bi-level device, maybe a ventilator, to a durable medical equipment company to start home ventilation. A respiratory therapist goes to the family's home or the bedside in the hospital in a initiation session, sets the machine up, dials it, teaches the patient family member how to use it. And maybe they come back a second time if the person didn't get it the first time, but the job of that respiratory therapist is to get the person to use it more than 4 hours a day if possible, so that the company can continue to provide that service to the patient. That's what they need to do to continue their services. So when the machine is no longer providing adequate support, very often that person is advised to consider tracheostomy or hospice because, well, the machine is failing. It's no longer giving you comfort in your breathing or decent sleep, so time to rev up to a tracheostomy, or maybe it's time to switch altogether into hospice care. This is happening so often. As the disease progressed, when the settings are the same initial ones adjusted just by eyesight to the patient's comfort to get them up and running, now their disease has progressed. The respiratory care hasn't caught up with their situation, and this is not a box that you turn on and off. It's a whole therapy, and so too often people are giving up on non-invasive ventilation when the care hasn't geared up to the person's current needs and purpose, and facing this question prematurely. We pretty much don't do trachs anymore. So there's another scenario you're all familiar with. Person is just toughing it out, trying to get by day. All of a sudden, they can't breathe, they're suffocating, 911 to a hospital, intubated pretty quick to a tracheostomy. That's not a planned tracheostomy, that's not all organized, and they go home without the preparation and the training that's necessary to deal with critical care in a household. So that's common and prevailing course of events in ALS across much of the United States today, and I know that because I see patients from all over, and second opinions on trach versus hospice, and the machine is totally inadequate, their care is inadequate, and that's the answer for them. So, explosion in knowledge and how to do non-invasive ventilation, number of publications in this area from 2012 to 2022, and really remarkable advances in the technology. All kinds of tools available now, different manufacturers and different devices to serve different elements of respiratory supportive care in this disease. And this is just frankly extend beyond the expertise of a neurologist who's got all kinds of things a neurologist needs to know, and beyond a respiratory therapist who's employee of a home care company without physician supervision, without requirements for continuing medical education. It's just way beyond our current model. So what I'm proposing here is a new paradigm for care of ALS, just flat out. Hey, person with stroke, is that a neurological disease or a cardiovascular disease? Well, most people would say it's both, and you need a cardiovascular team and a neurology team fully developed with all their resources working closely side by side together. I maintain that ALS is a neurological disease and a respiratory disease. Respiratory failure is front and center in what we do. It's a neurological disease and a respiratory disease, and care is best served when a neurologist and a physician specialist in chronic respiratory failure collaborate in what I'm calling here co-principal care, from diagnosis or shortly after till death. Here's what it looks like. There's a neurology team, kind of like that pie chart we saw before. Same team. And side by side, closest possible, there's a respiratory team. Now this team takes care of other diseases besides ALS, on into COPD, whatever causes respiratory failure. And the respiratory team watches over respiratory care. Most of us are trained in critical care. We're very familiar with enteral feeding and how enteral feeding interacts with respiratory system. And hey, we know our colleagues in internal medicine, so we can help identify medical comorbidities and help people early on get connected into optimal care for those other conditions that can eat away at the experience of ALS in the background. So a teamwork, two teams, co-principal care, leg neurology and cardiovascular medicine in the care of stroke. The goals for the respiratory team are these: enable restful, restorative sleep, assure comfortable breathing when awake, to the extent possible, spare people running out of breath, experience of suffocation, whether it's for a few minutes or days or weeks, and then maintain good physiology by normalizing gas exchange, nighttime as well as daytime, normal oxygenation measured by oxygen saturation above 92% and normal CO2 within the normal range 35 to 45. So restore physiological homeostasis. Those three things are achievable for a large fraction of people with ALS. So let me outline what optimal care might look like. We're going to go from an early referral to early initiation of care to physician-directed, not respiratory care directed, physician-directed respiratory care supported ongoing care. I'm going to make a case for early initiation of tube feeding and advanced planning to take care of respiratory infections at home so that to the extent possible, people don't have to 911 into a local hospital that knows nothing about this disease and home ventilation and gives oxygen for hypoxemia instead of turning up the ventilator, all the things that happen. So, and then I think pulmonologists with our experience in intensive care units can make a critical contribution to end-of-life care in this disease. So here we go. What I'd love to see is neurologist makes a diagnosis. So much happens at that time. Oh man, heavy duty. But early after that, whether it's the second or the third visit, recommends that meet the pulmonologist heading the other team. Now, even if there's no apparent respiratory dysfunction at that time, so that we can get to know the person, go through those other medical morbidities to figure out what needs to be optimized in advance, begin to give them an idea of what they might expect. That's a leaning in part of this. Earn their trust, and to be there for them in parallel with the neurologist from that point forward. So early on, before catch-up time, before tracheostomy versus hospice, which is, when we see in our patients still just the last year or so. Medicare, CMS in the United States has criteria for starting home ventilation. If you're in this business, you know about this. And that's way out of date. I think it's 1989. A lot of research since that time favoring earlier initiation of home ventilation than are the current criteria. So by hook or by crook, by tricks and gimmicks, we're advocating for earlier initiation of home ventilation than is currently the Medicare standard. And consensus United States and Europe growing around starting home ventilation when two conditions are met, a forced vital capacity less than 80% predicted. That's abnormal if you have normal lungs. And symptoms of respiratory insufficiency: uncomfortable breathing, interrupted, unsatisfying sleep that can't be attributed to something else, and orthopnea. Orthopnea is inability or discomfort lying flat. That means your diaphragm is way out of here. That's not a very good diaphragm. I don't care what the vital capacity is. Sometimes there's trouble measuring vital capacity, but hey, if somebody has a lower than artifactually low vital capacity because of difficulty making a seal, kind of helps us get to home care earlier. It often takes a long time to get somebody up and running. It's trial and error with the machine and with other stuff, and they have to accommodate to a different kind of lifestyle. So having a period of time to acclimate into home ventilation before crisis, before it's really need, is really a part of this benefit of starting early. Three tools for assisted ventilation that pretty much everybody should have. A bi-level device, a ventilator with a heated humidifier, an interface, a face mask, and a pulse oximeter. BiPAP, everybody calls it BiPAP. That's a proprietary name of Philips Respironics. It's like Kleenex instead of tissues. You know, I know what you're talking about, but if you want to show you know your way around this, you call it bi-level ventilation. And that's a little bit different from a ventilator. These are bi-level devices. They're made to be used at stationary at a bedside. They're compact, and the most advanced versions of these are pretty capable. They often have the humidifier built into the chassis. Not so hard to carry this thing around. These are bi-level devices. And then ventilators derived from intensive care, from hospital ventilators, have a great deal more capacity. Very importantly, they contain a battery. So ventilators are really valuable and important when somebody needs assisted ventilation during the daytime and they want to get up and out of bed. Overlap in these, but the argument for a ventilator becomes progressively greater as a person becomes highly dependent on this to stay well, and as they want to move around during the daytime. The selection of one for the other is quite a complex discussion. There are more than 200 face masks available today in 4 major configurations: nasal, over the nose, under the nose full face mask, over the nose full face mask. Those are the major configurations. And fitting a face mask is an art to itself. We might go through 3 or 4 or 5 of these, just trying to get something that's comfortable and doesn't leak. So there's a big art in this, and one of the reasons to start early is to find the right mask. And some people will end up with more than one: a day mask, a night mask, a this and a that mask. The bi-level devices have their own humidifiers, ventilators. That's an astral ventilator there on the table with an attached heated humidifier to a nasal cushion mask. You don't have to do this for non-invasive ventilation. It's not required, and some people would rather get rid of that machine. But dry nose, dry mouth, this is the solution. I recommend that ALS patients get themselves a pulse oximeter. There are a variety of questions that can be answered with them if they're well educated on how to interpret it, how to recognize artifacts, and what it tells you when. I like Nonin, company Nonin, or Massimo. There are many $15 pulse oximeters out there that aren't really medical grade, and a person with ALS deserves a medical grade oximeter. So known and go-to is a favorite. Fingertip pulse oximeter, I think $30. And to the other side is this interesting thing. That is a thumb device. You put it over your thumb. It sits right here, and it's, you can move around with it, you can sleep with it, and it transmits Bluetooth to your cell phone so that you can have an overnight or continuous recording of oxygenation. And if you're a little more tech-savvy, you can plug this little thing into a computer with a different set of software that will give page after page, minute by minute, oxygen saturation in a graphical form, plus all the summary statistics that for an engineer with ALS, this is a godsend. But it also provides very valuable information to the patient and how to manage, for example, an acute infection. When is it time to go to a hospital, and for many other reasons. So these are two devices that I can recommend. The one on the right is about $170. On your left, your right is $170. All right. The two main respiratory goals we have are support failing chest pump and protecting the lungs. Today we can, using non-invasive ventilation, carry most people as far as they want to go in this disease without a tracheostomy, including many people with bulbar disease. Not everyone. There are some circumstances where we just can't get an open airway or some other problem where we can't make non-invasive ventilation go the distance. So the longer a person goes with non-invasive ventilation, the more likely they are to get into trouble with their lungs, with aspiration, retained secretions, infections that don't clear. And you're all familiar with this if you're in this business of chest congestion, atelectasis, collapsed lung, mucus plugging, a dropping oxygen not explained by a failure of the chest pump, but by progressive lung disease. And now, more and more often in well-cared-for patients, a cause of death is lung failure rather than respiratory pump failure. So we put about equal emphasis into protecting the lungs as we do into assisted ventilation. And there are a variety of tools for this. We'd like to begin a program of airway clearance, maybe even ahead of, but certainly at the time somebody is complaining of chest congestion that they can't easily clear. And then there's a little measurement. You can do this if you want, or a pulmonary function lab can do it, of a cough peak flow, coughing into a spirometer basically, and seeing what the peak flow is after that cough. And there's a threshold at which cough is no longer effective. That would be an indication for really getting hard and heavy into airway clearance. So three main devices here that I like. There are others, some other people like, but a cough assist device, a suction machine, and a nebulizer. I don't see personally much use for a therapeutic vest, the common in ALS. They vibrate the stuff down in your chest, but it doesn't bring it up and out. The cough assist device is the key device to bring mucus from the central airways up and out. The main cough assist device in use in recent years is a Respironics T70, shown there, cough assist device. Another company is making a good, strong competitor to this called Biwaze, B-I-W-A-Z-E. And Philips is having a lot of problems right now, so we're more and more using the other device, a Biwaze device. Suction apparatus is used to clear the rest of the way. The cough assist machine brings to the back of the mouth, and if people can't spit that out of their mouth, then you need a suction device to get. And a suction device with a different adapter can be used as one strategy for clearing out the nose. Cough assist device can be used to stack breaths, and in fact, that's what it does. It fills your chest and then sucks the air out again. Well, if you suck out through the mouth, that's a cough, but you can make the forced exhalation through your nose, and that can help clear the nose. So it can be used to clear the nose as well as the airways. Suction device to take it the rest of the way. And then a nebulizer is just a device for adding a nebulized liquid into the inhaled air. That can be a bronchodilator, or it can be hypertonic saline. Draws water into the airways to help loosen and dilute secretions within the airways that might be desiccating and hard to pull out. So, and the nebulizer, is many people appreciate that as a tool to moisten their chest before they use the cough assist machine, followed by the suction device. We're talking about a lot of machines in there, a lot of stuff on the shelf and on the floors. Voxen is a 5-in-1 multifunction device. V for ventilation, O for oxygenation, C for cough assist, S for suction, N for nebulizer. These are 18-pound machines that can be carried around. They're complicated. It's very elegant design, but you've got to put different attachments onto these things and shift it around, and they're so complicated they tend to break down and need to be replaced. It is an elegant solution for some people who don't want the clutter of all those other machines, but it's not really playing a big role in our ALS care at this point. Some people are coming out of the hospital with them, and we just manage them forward. Just now, they have an advancement that makes them a little more attractive that I'll describe. So that's the technology, and we're saying time to take respiratory therapists out of the driver's seat, put them right next to the driver as a team, and have physician-directed respiratory care, including the details of all this technical care. There's so much to be learned. The technician doesn't prescribe and manage and determine the settings for dialysis. Well, this is dialysis of the lungs. This is life support for the respiratory system. The technician supports the physician. That's the way it should be in ALS. So the heart of our program is what we call a titration. This is our outpatient office. That's the guy on that water board. That's our respiratory therapist. I'm taking this photograph, and we're doing a titration. He's wearing it. We're modifying, trial and erroring the settings. We have shelves full of masks. Bring in a mask like a shoe store. You don't like this one? Let's try that one. And looking at data and asking him very focused questions about his experience of this, trying to get this right in the office. That's a titration. And the default is respiratory therapist sets the person up in the home or in the hospital. 1 to 3 weeks later, we're seeing them with their machine and spending 40 to 80, 90 minutes at this in the office, refining the whole setup. That works sometimes, but it's not uncommon for us to have to bring them back 1 or 2 times more, getting closer and closer to the mark. And the disease is progressing, so this needs to be done at intervals. 3 months for rapid progressors, slower for slower progressors. This is an ongoing physician-directed optimization of home ventilation. Part of the strategy here is getting the mask right, and here's a woman trying on the third mask with a bilevel device in the background. We use 2 monitoring devices in particular after we started home ventilation. and one is a transcutaneous CO2 monitor. This now is the best non-invasive technique for measuring blood gases, PCO2 as well as oxygen. And it's replaced blood gases. Rare is very, very rare. Once a year, are we doing a blood gas? This is Genentech. There's another company, Radiometer, that makes a competing product. The green number at the top is the CO2. It's straightforward. Perhaps you can see the wire to her ear, to the sensor just attached to the ear. It's like a pulse oximeter, but you got to get it right. So you have to follow the directions to get it right. Every patient on every visit we do this. And we're looking for hyper as well as hypoventilation. The other main tool we use is home telemonitoring. This is have been available for a while for Philips devices and ResMed. Now the other companies are catching up. Voxen is just now able to have transmission of device function to the cloud that you can access by username, password. Brias, Lowenstein, the other companies are catching up with home device telemonitoring. There you see next to a astral ventilator is a telephone, Bluetooth to that telephone device, 1 to 3 or 4 times a day. It's telephoning central servers with an update on the device function. And by username, password, we can get in and see a very elaborate report on how the machine is functioning, tidal volume, minute ventilation, pressures, leak. And this is telling us what's happening at nighttime. In the daytime, sitting up in an office is one thing. Put that same person lying flat at home at night, very different. So in every instance, after an office titration, 3 days later, we go back in and take a look at this. And maybe we'll call the patient, how are they doing during sleep? And we're looking at this numbers, and very often we know that we need to bring them back for a second time around or a third time around. It's a price to pay up front to get ventilation going. This is just a huge leap forward in home ventilation. Now it's looking like an intensive care unit where we have monitors on the wall. Well, here's a monitor right on your office computer. All right, so there's one well-established indication for tube feeding, that's weight loss. You know, that's inability to swallow, but also it's hypermetabolism. We don't really know if tube feeding improves survival from weight loss, although most people think they'd rather not starve to death. Well, the other main reason is to reduce the volume of aspiration and the character of aspirated contents into the lungs by progressively shifting nutrition away from the mouth and to the tube. We don't have evidence to prove that prolongs survival. But when we put a tube in fairly early on, before chest congestion or around that time, just about everybody buys in, and they shift their nutrition farther and farther to the tube, giving up feeding, so they're, by their feet, by their actions, indicating back to us gratitude at having a tube in place. You don't have to use it. You can use it in any variety of ways. We like to put these in early as much to help protect the lungs as to help maintain nutrition, and just have not had negative experiences to dissuade us. This can be done on an outpatient basis by interventional radiology now, and with non-invasive ventilation during the procedure, you don't have to worry so much what the vital capacity is anymore. Do it at the right time with respect to protecting the lungs and protecting nutrition, and don't worry so much about vital capacity. All right, so everything's all set up. Now a person's at 18, 20 hours a day, have whole elaborate setups for daytime ventilation, mouthpiece ventilation, a person is at risk for lung infections, terrible experience, and worse, the premature death. So we like to prepare people and give them a kit of an antibiotic and maybe some prednisone and instructions for how to manage the beginning of an infection at home, how to interpret their pulse oximeter, that this is an infection and this is a tolerable one or a dangerous one. And to the extent possible, with some telephone input from us, manage infections at home up to a certain point, and then maybe it's a controlled transfer to the right hospital rather than 911 to a small community hospital that's not prepared for this. So preparation for lung infections is a very important part of what we do. And my academic background is in palliative care of respiratory failure in ICUs. I know this neck of the woods quite well. Most people today in medical ICUs die after palliative withdrawal of life support under titrated sedation. We don't have to go to the last 10 degrees of systolic blood pressure with sepsis anymore in an ICU. So that's a usual and expected and ordinary part of intensive care, but it hasn't penetrated outpatient care of people with progressive respiratory failure to any appreciable extent in the United States. And that's a shame. It's so comforting for many people with ALS to know the doctors, the teams will be there to maximize their function, their independence, to minimize their suffering, to maintain life support as long as the patient wants it, and then to help support a graceful, dignified way out when they've had enough. To be able to anticipate and be able to think, hey, I can get out of this without suffocating to death, is very comforting to many people as they get to that point. All kinds of things happen in the real world, but to have this as an option, I think, is very important. But you can't admit an ALS patient to an ICU for turning off the machines. We can scam it, and many people don't want to die in an intensive care unit, and hospices don't really do this. They just don't. They would need to have a team of very well-trained people on call to go manage and supervise the last 8 hours to 3 or 4 days of life. Maybe not continuously in a hospital, in the home, but with a fairly high level of care, and they just don't have those teams under their capitation system of reimbursement. So this kind of, maybe some of you have experience with it, but it's kind of not available in the United States, and what a shame. So too many people with ALS get to this point, and they're ready to die, and they've lived their lives and they don't want it anymore, and they're just lying there waiting for a terminal pneumonia that's not going to be treated. Sitting there waiting for a terminal event rather than having some control over how this unfolds. So we would like to see, in collaboration, neurologists and pulmonologists and palliative care physicians, development of an option here. New Jersey has a right to death law, so it is possible for a physician to write an overwhelming dose of sedatives and opioids, even before dependence on ventilation, but not in my state of Pennsylvania. This is a place to be developed in collaboration, us and neurologists. All right, so I want to close here with a request for advocacy. Breathing is everything when you can't. This is a time to start advocating for a great expansion of ALS respiratory care across more centers in the United States, and for research in this vital, supportive part of care. And it's possible. Recently, the NIH released a draft report outlining priorities for research in ALS for the next decade. It had almost no mention of the cause of death of this disease, respiratory disease. My colleague at Penn and I, we organized a group signature letter from clinicians saying, get with the program here. And some friends of ours, Randy Fishman of the Fishman program and Everything ALS, got together and created a petition that pulled out 695 signatures that went to the NIH, double hit advocacy, and what came out the other end was a research prioritization that then prominently and appropriately included supportive respiratory care. So how advocacy can work to change the direction of things. There's an opportunity right now to do something very similar. The National Academies of Science, National Academy of Medicine, is launched a inquiry into ALS, accelerating treatment, improving quality of life. They're meeting a few weeks from now for the first time and very much inviting people to go in person or to write in comments for a strategy that they would develop for improving quality of life in ALS. And we would love to see people say, hey, you have to include respiratory management side by side with some of the other stuff. Find this online. You see right how to put in a written comment or when to go to their meetings. One other thing, this is an ALS Association session. Time for ALS Association to modify their recommended paradigm into co-principal care. It's time to catch up. ALS, I said the ALS Association, Muscular Dystrophy Association, what an embarrassing mistake. But MDA, catch up here. ALS Association hasn't made a step in this direction. Well, maybe you guys can lead the way by changing the paradigm that this organization recommends into co-principal care. And very concretely, there's something that can be done to quite accelerate this, and that's to put together a curated, a vetted registry of neuromuscular disease respiratory care programs across the United States. Side by side with the neurology-based programs is the respiratory-based programs, so that somebody can look up and find out where there is the closest Fishman program equivalent to them at their own center. Maybe it helps them decide which neurology center to go to, because you get two coordinated teams. So there'd be some criteria for this, including close coordination with a neurology program. I'd love to see MDA take a forefront in establishing this as a new standard of care for people with ALS and other neuromuscular diseases. MDA ideal, because this model I'm talking about is equally as appropriate for SMA and muscular dystrophy and all the other diseases on the MDA list. All right. Patient of mine with a ventilator on the back of a tricycle. Breathing is everything. Thank you very much, folks.